Good afternoon, and thank you for joining us for our fourth webinar in the COVID-19 webinar series from the College of Health and Human Services. I'm Michelle Thompson, and I'm pleased to introduce you to Department Chair of our Social Work Department, Emily Ihara, who will be playing the role of moderator today. Just a few quick notes before I turn it over to Emily. We will be taking questions throughout the session, so please feel free to submit those to the panelists, and we will answer as many of them as we can get to today. Thanks so much, and without further ado, I turn it over to Emily.
Good afternoon. Thank you, Michelle. On behalf of the Department of Social Work, I want to thank you all for joining us today. As you can see, we have a very interesting group of speakers, and before we begin, I'd like to provide a few remarks about why we think this is a social justice issue. As many have said in recent days, we are in the midst of two pandemics: the long-standing pandemic of pervasive and systemic racism and racial injustice, and the COVID-19 crisis. When we had originally planned for this webinar, the connection was already clear to us that COVID-19 brought to the forefront the social justice issues of workers in the United States. The pandemic has exposed deep vulnerabilities in our economies and our society. And just as those with pre-existing health problems are more likely than their healthy counterparts to face serious complications and even death if they become infected, low-wage part-time workers and small businesses are most at risk from the pandemic-induced economic depression. Our society has failed to guarantee a safety net and protection for its people, including guaranteed paid family leave and sickness benefits, affordable health care, robust pension systems, and living wages. Next slide, please. So there's no doubt that the healthcare workers have, so this actually is our distinguished panel, and I will be introducing them after a few more remarks. So next slide, please. So there's no doubt that the healthcare workers have and continue to risk their lives daily to care for all of us. The Kaiser Health News and The Guardian has found that nearly 600 frontline healthcare workers have died of COVID-19. And this tally includes doctors, nurses, and paramedics, as well as critical and crucial healthcare support staff, such as hospital janitors, administrators, and nursing home workers. A majority of those documented were identified as people of color, mostly African American and Asian American and Pacific Islander. And while there's no comprehensive accounting of U.S. healthcare worker deaths, this tally is extremely important so that we understand who are these essential healthcare workers. The CDC has only counted 368 COVID deaths among healthcare workers, but acknowledges that this is an undercount. Next slide, please. As Northern Virginia moves to phase 2 on Friday, we want to make sure that the stories of other essential workers do not get lost. For almost three months now, we know that not all workers have had the luxury of working from home. And where physical distancing is not possible, an immediate serious problem was the lack of personal protective equipment and unsafe working conditions. The workers who are at the highest risk in these industries often do not earn a living wage and do not have any or adequate health care or leave benefits. Many of these essential workers have had and have no choice but to work. When your job is deemed essential and you have to choose who are allowed to work because their job has been deemed essential. The structural inequities and racism that puts African Americans and other people of color at higher risk for death by COVID also puts them on the front line. And so we want to remember who these essential workers are. The Economic Policy Institute has done an examination of the demographics of essential workers by industry, and some key findings have been that women make up the majority of essential workers in healthcare, 76%, and government and community-based services, 73%. People of color make up the majority of essential workers in food and agriculture, 50%, and in industrial, commercial, residential facilities and services, 53%. Nearly 70% of essential workers do not have a college degree. 3 in 10 essential workers have some college or a high school diploma. and 1 in 10 have less than a high school diploma. So much of this work that they are doing that has been deemed essential is often underpaid and undervalued. Next slide, please. So as we think about not only the essential healthcare workers and the workers who continue to go to work when they were considered essential, our focus today is on 4 distinct organizations that are serving vulnerable populations. So we'd like to play this short video from Neighborhood Health that helps illustrate the essential workers and those they are serving.
It's life or death, and it's life or death not only for an individual, but for multiple members in the family and community members as well. In many ways, it's hidden. The person working behind the cash register, the person delivering your food, the person cleaning the office building. These are people who are getting impacted in far greater numbers than others in our community. And we really can't forget them, especially as there's talk about reopening. What does reopening mean? It means that a lot of us will be able to partake in certain activities, but there's certain communities that are going to continue to be more at risk. And we really need to do whatever we can to look after their interests, not only because it's the right thing to do, but also because ultimately that impacts everyone. If the epidemic or the pandemic is not controlled within our low-income communities, then we're not going to be able to control it overall as well.
So that was on the local news. So the clip can be found, maybe you can see a clearer picture of it. So I'd like to now introduce our panel. And so if we could go to the next slide. So we have four wonderful people on our panel today. We have Gadhia, who's the Chief of Policy Research and Programs at Childcare Aware of America. Courtney Riggle-van Schagen, the Director of Behavioral Health at Neighborhood Health. Kay Halverson, Executive Director at Mary Marshall Assisted Living of Volunteers of America. And Debra Evans, the Division Chief at Sexual Assault Center and Domestic Violence Program of the City of Alexandria. So we're going to start, our webinar is going to be more of a round of questions. So our 4 panelists will be responding to the questions that we've prepared, and then we'll open it up to the audience for further questions. So we can go to the next slide. And for our first question, we're going to also ask our panelists to introduce their organization and answer this question. So the question is, how has your organization or industry continued to provide critical services to the community? And what were unexpected changes that were required? And so we'll start with Ami.
Hi, thanks so much for having me. Childcare Aware of America is a leading voice for childcare. Our mission is to advance access and affordability to high-quality childcare for all families. We're based in Arlington, Virginia, and our members are made up of over 460 what are called Child Care Resource and Referral Agencies, or CCR&Rs, all around the country. They're in states and at the local level. These CCR&Rs help parents find quality childcare in their communities, and they help childcare providers stand up their businesses and meet the different regulations and other standards that are needed to stay in business and serve their communities. To answer the question about how CCAOA has continued to provide critical services to the community, we've done a number of things. We have stood up a center, it's Emergency Child Care and Technical Assistance Center, for our members. It has a hotline, an email chat line, and has an online chat an email and a hotline, phone hotline, to take questions from our members, as well as from care resource and referral agencies, as well as from the providers they serve, to understand how we can help them. CR&Rs are helping providers in many, many different ways, everything from being the purchasing hub for cleaning supplies that child care providers need to be able to safely serve the children of essential workers, which are defined broadly, as Emily just talked about. We've also continued our advocacy work, and I'll get into that a little bit later with one of the other questions, but we continue to press Congress very strongly for support for the child care system, which was already in a tough spot before the pandemic hit, and is in an even tougher spot now. Surveys show that child care providers may never reopen after the pandemic is over, and to prevent that from happening, because it's a threat both to the livelihoods of the providers and to the families they support, we are advocating that Congress do much more to step in and help providers. Just briefly on the unexpected changes that were required, I think not knowing how long we were going to be remote was certainly one of them. And then not really knowing how to translate some of the public health advice that was being given from CDC and others to the care setting was also unexpected, right? I mean, young children can't be expected to wear masks and to socially distance. So those are some of the things we've had to grapple with.
Thank you. Courtney?
Yeah, thank you so much for having me. And I just want to credit Jay Korf at WJLA for the teaser that we played, and that story did run several weeks ago. So Neighborhood Health is the largest federally qualified health center in Northern Virginia. We serve more than 30,000 patients across the region, and we provide comprehensive health care to underserved communities. Our mission is to advance health equity and improve health outcomes for patients that experience barriers to care. So our care includes primary adult medicine, women's health, pediatrics, behavioral health, dental care, prenatal care, and pharmacy services, as well as a variety of other ancillary services in addition to that. And I'm a licensed clinical social worker, so I've been a part of Neighborhood Health for over 14 years. So until recently, a large part of my role was to focus on the integration of primary care and behavioral health services. And in the context of the pandemic, we have shifted our focus to respond to the public health crisis and how we should be delivering critical healthcare services to our vulnerable communities, which includes thinking about how our communities get the information that they need, how they get the resources that they need, how we prepare and support our workforce to deliver the care when it's most needed. So in the context of COVID-19, we've really shifted our response to address those issues. Some of the changes that we have made include testing. We've conducted over 2,500 COVID tests since the start of the pandemic, and certainly the management of our patients with COVID positive test results. Our family support team has partnered with local food banks to deliver food directly to patients in service areas where it was difficult for patients to access that resource, and where this presented a barrier for patients to successfully isolate while they were ill. We're delivering masks and thermometers and pulse oximeters and medications as well to patients who are COVID positive. We're partnering with all of the local jurisdictions that we serve to facilitate referrals for patients to isolation and quarantine hotels when patients are unable to isolate or are living in congregate living situations. So none of these services were things that we were previously providing, but all of them are really critical to the health and safety of the community. And the other really significant change across the organization is that we've transitioned the majority of our services to a telehealth model of care, with a few really specific exceptions. And telehealth really allows patients to receive many of the same services without the risk of exposure to COVID, and also protects, our staff from exposures as well. But I think it's really important for us to be mindful that there are some drawbacks for patients who struggle with access to technology, with issues of privacy, who have limited resources. And so there are, there's some balance issues there. The benefit, of course, is that telehealth really limits exposure, and it allows patients to remain connected to their medical providers, their behavioral health care providers, and their dental providers, in spite of, in the midst of a public health crisis.
Thank you, Courtney. And then we'll go to Kay Halverson.
Hello, and yes, thank you so much for having me on your panel. Mary Marshall Assisted Living is a residence for 52 aging seniors in Arlington County. We are in partnership with Arlington County. The people in our residence all have a diagnosis of a serious mental illness or an intellectual disability, are low income, and over the age of 55. So we service a very specific niche in the community. And we have been open since November of 2011. And are currently full. We do have 52 residents at this time. As far as unexpected changes that we have seen, we have been through epidemics before. We've had the norovirus go through, and so we know about shutting down congregate dining and canceling activities, keeping people apart, having separate serving meals in rooms. But what we found here with the pandemic is just an extra layer of things that we weren't quite anticipating. I think certainly the most significant thing is just the duration of how long this is going on. When we had the norovirus, it was a week, and then we were kind of back to normal. The other thing that we can be very grateful for is that we do not have any positive cases in the building, which has been wonderful. We're one of the few long-term care facilities in the area that has not. So every day that I go home, I say it's been a good day when we don't have a positive case. But as the result of that, our people feel fine. They feel healthy. So we've had to insist that they wear masks, that they social distance. We've had to physically rearrange furniture and take chairs out of areas to keep people apart. And when they feel fine, it's kind of a difficult thing for them to accept. But for the most part, they've really been pretty cooperative with it, and we're doing, okay with it. The other thing that happened that didn't in previous times that we've had to kind of isolate is we lost our cleaning crew. We contract with Job Discovery, which is an organization that provides work for people with intellectual disabilities. And so, of course, as soon as the pandemic hit, they were out of the building because we were restricting people coming in. There's no visitors. Deliveries are done in a different manner. There's no, everything is just, it's pretty much our community. And so we have staff here have had to pick up all the additional cleaning, all the additional sanitation procedures. So those are the things that have really been the most unexpected things that we had to deal with. Going into, we thought, oh, well, it'll be just like norovirus. Well, we soon found out that wasn't the case. So that's kind of, in a nutshell, how we've had some unexperienced things.
Thank you. And then Debbie Evans.
Thank you for having me as well. So I am Debbie Evans. I'm the Division Chief of the Domestic and Sexual Violence Program for the City of Alexandria. And as you can imagine, our program provides an array of services. So we do have the 24-hour hotline for both the domestic and sexual violence programs, as well as we provide individual supportive counseling, short-term therapy, court and legal accompaniment, as well as hospital accompaniment, and we also run a 24-hour safe house. And so as we know, domestic violence, and especially during this time, and sexual violence can be extremely dangerous for survivors. So we could not stop any of our services. We needed to ensure that survivors had access to our hotlines if they needed to come into the safe house because they were in danger due to domestic or sexual violence, that they had access to those services. if they needed to apply for protection orders or they needed police involvement, we needed to ensure that they did have access to those services as well. So we had to do a lot of shifting in our services because we could not stop any of the services. So most of our services have gone telephonically. And so as domestic and sexual violence programs are under the Violence Against Women Act, we are bound by strict confidentiality that we cannot share any personal identifying information. And so looking into telehealth website or platforms, looking into those, we had to ensure that they complied with VAWA. And doing a lot of research along those lines, there's only certain platforms that do comply with what we call VAWA, that has the strict guidelines. So looking at the different platforms and seeing what will work for our clients as well. And as Courtney had mentioned, the access to technology on clients, because a lot of our clients are lower socioeconomic that we work with as well. So trying to still have them access services since we are not doing in-person services was a little bit of a challenge as well. And then we also have the safe house, so we can't stop running that. So if somebody needs to come into the safe house because they're in danger and they're COVID positive, what do we do in that situation? So not everybody in the safe house infected with COVID. So we've been working a lot with neighborhood health as well as the health department to ensure the safety of staff and clients as well. And I think that some of our biggest challenges have been figuring out the technology and providing telephonic services and what's going to work for our clients so that they still are getting their basic needs met.
Thank you all. That's interesting, right? There's been so many different approaches. So can we go to the next question? So our next question is, how has your workforce been impacted by the intensity of your COVID response? And are you anticipating any psychosocial factors that may need to be addressed among your workers? As we think about, right, like sort of the long-term effects of being in crisis mode for a continuous amount of time, we anticipate that some of this might start to take its toll. So we'll start again with Ami.
Thanks, Emily. So the childcare workforce has been impacted in one of two ways. Either they have had to shut down and they are not able to support themselves. The unemployment insurance that the federal government provided will be running out, as I understand it, in July. And childcare providers are extremely underpaid and undervalued. The average wage for a child care provider is $10.72 an hour, so far from a living wage. So either folks have been out of work and really unsure how to support themselves and their families, or if they have been taking on, if they have been open and they've been caring for the children of essential workers, they've got significant fears about catching the coronavirus themselves. 40% of the child care workforce is women of color. And as we all know, African Americans have been disproportionately impacted by the COVID-19 because of the public health impacts of centuries of systemic and structural racism. And so we are trying to support providers in either one of those very, very scary situations, either by getting them the supports they need, the financial supports they need to support themselves and their families and keep their businesses afloat, or to get what they need to open safely and to protect themselves and their employees. But the experiencing whichever one of those two roads they're going down are going to need to be addressed in the longer term, and we're going to have to advocate for adequate mental health and financial supports for child care providers.
Absolutely. Courtney, what's happening in neighborhood health?
So many of our staff come from the communities that have been hardest hit by the pandemic. And so as a result, we've seen impacts in our workforce in a variety of ways. We've seen the economic impact as multiple income earners in our employees' households have lost their jobs, and then our employees become the sole financial support system for the household, or in some cases, they're now supporting multiple households. As you might expect, we've seen employees test positive, and it's certainly difficult to identify the source of the exposure, but we know that some of our staff have reported other household exposures. Some live in multi-generational households and shared households, and so certainly that's one possibility. And in addition, we know that many of our employees are living in communities that are experiencing extremely high rates of community spread. Many of our employees, to Ami's point, are impacted by the loss of reliable childcare, as the childcare industry is being impacted as well. Many of our employees rely on public transportation to get to work, and the public transportation system was really impacted, was reduced by the pandemic. So those are all, factors that have impacted our employees. The other issue that we have seen with regard to our workforce is that many of our employees have roles that don't lend themselves well to telehealth. And so they're asked to come into the office, at least on a rotating basis, as essential personnel. Providing on-site testing is, one example of that. From a psychosocial perspective, we are concerned about the, sorry, getting a flashing, there we go. We're concerned about the issue of staff burnout and the impact of asking our employees to routinely work in situations where there are very high levels of anxiety, both for their own health and safety, but also for the outcomes of patients who are really critically ill, and to do that day after day. And I think the other aspect of that is a real concern about the impact of secondary trauma for our workforce and how this is going to continue to impact our employees in an ongoing way. Even as the levels of positive cases start to recede, I think what we're paying attention to is that our teams may now start to begin to find time to process and to talk about their experiences more than they've been able to up to this point. On the other hand, there may be some anticipatory anxiety about a second wave in the fall. And I don't think anybody is really sure how our healthcare system is going to respond emotionally to the stress of that burden. I'm hopeful that our teams are going to feel some sense of efficacy and a sense of preparedness to meet those challenges, that we've been through this before. We know what this looks like, but I don't think that that we really know what that's going to look like.
Thank you.
Can you hear me? Am I on?
Yes. Yes,
oh,
you're on.
Right. Pushing the buttons, Of course, we are all essential staff here, and so when everything started to shut down, we were forced to restrict a lot of things, but staff are still coming and going each day. And I think one of the greatest things that we've had to kind of deal with is just restructuring of staff responsibilities. With our dining area being closed, we've taken dietary people and we've put them into some housekeeping roles. We have all chipped in to do some different sanitizing things. One of my job responsibilities is I clean the lobby bathroom once a day. We're all doing everything that normally maybe other things would get done, or other people, we've taken on extra things. So staff are working harder, and they're also not getting any time off. And that's a huge thing. When you think, I know several people have canceled vacations, time off. Now, if we have told staff if they need a day off, to work with their supervisors, and we're going to make sure for mental health reasons that they get a day here or a day there. But there's been no extended time off. We are just starting to think maybe next week we can actually give people a few days off in a row to give them a break, because with all the residents here, nobody going out, it really does mean that we need to have all hands on deck. So it has definitely been impactful for them. The other area that we kind of weren't anticipating either is the whole shutdown in the metro transportation system. We have several people that rely on public transportation. So we are picking people up, dropping them off, rearranging shift schedules so that we can accommodate. They're here for a longer period so that we can make sure that we can get them back and forth. So there are all those things that are kind of just changing and evolving, and they do that almost on a daily basis, although we have some structure to our new normal. It's been definitely one of those things that has impacted staff. I'd say one of the things that we're very fortunate about is we operate as kind of a family. We do support each other, and we always have viewed every person in the building as essential as the next person. So knowing that no one person can fully operate a building, you need a whole bunch of different people to make it go. And we went into this knowing that, and I think that's helped with our morale to keep us keep us afloat, because we're all supporting each other, and we all realize that all our roles are valuable, and no one person overshadows another. So that's been a plus for us, but it has certainly been difficult. And I think that the longer this goes on, and we are going to be one of the last places to open up because of our very vulnerable population, we're anticipating more and more of this. We're going to have to be kind of creative with how we're going to make sure to get time off and to get some additional people hired.
Yes, that's quite a list. And then Debbie.
Thank you. So I would say the biggest shift for our staff is actually taking everything and making it telephonically or telehealth. Was a huge shift for staff members, because they're so used to seeing clients in person and having the contact in person and being able to do that. So having to shift all of our services to a different means of providing those services. We are still responding out to the courthouse if somebody is applying for a protection order in person. So we had to reduce staff, but always have 2 staff members available to respond out, answer the hotline. So we are continuing those services as well. And then also working in a domestic and sexual violence field, all of our offices were very close to each other. So if we needed to process with one of our colleagues about something that we just experienced with a client, what they just shared with us, and we were experiencing some type of secondary trauma, we were able to walk into the other staff member's office and kind of process, or if we needed suggestions and ideas, we were able to do that. So now we have to be intentional about reaching out to our other colleagues, either by phone or video chat, and not mentioning clients' names and things along those lines to provide that resource as well. So it's been a little bit more challenging where we were able to pop our heads into each other's office and kind of process and debrief with the other staff members. We've had to change that as well. And then the other thing that we're noticing with clients, especially in the beginning, clients were not calling so much about domestic and sexual violence that they were experienced. They were calling more about not having rent money, not having food, the basic need items. So staff had to really educate themselves on the different community resources that are out in our community to refer clients to, so we could get those basic need items met. And so that was a different shift in the different day-to-day kind of case management, because we're so used to hearing about the domestic and sexual violence as the primary issue that we had to shift all of our, we have to meet the client where they're at, right? And so if that is the biggest need, the biggest item at this point, that is what we're going to work on and try to get the resources to that client. So it was really a mind shift for all staff to try to figure out, what are the resources out there? How can we help the client with this need? So it's really been relying on all the other staff members, the community resources, tapping into each other, and this is difficult for everybody. And so we also need to think about how this is affecting us. How is COVID affecting staff members? So being able to process that as well with the staff members, and I think that is actually the next question that we're going to be going into. So I'll speak a little bit more on that. But it's really, how do we keep two 24-hour hotlines running and during this time? So it's really adjusting staff, and staff are afraid to respond out because they don't want to be in close contact with somebody who potentially has COVID, ensuring that the staff member has the appropriate PPE. So if they do have to respond in person, to accompany them, and it has, it's been challenging to figure that out as well.
Thank you, Debbie. I think what's so poignant about everything that you have talked about, all of you, is how interconnected we all are. And how many things affect other things, right? Like the whole idea of picking people up to get to work, or to take care of each other in that sense of like being able to process what we're listening to or what we're experiencing, I think are all important issues. But then, at the same time, you're really dealing with folks who don't have their basic needs being met right now. We'll go to our last question, and then there's several questions that are coming in, so we can save some time for those. All right, so our last question is, what are the critical post-pandemic needs that you anticipate for your workforce or your industry? And some of you have spoken to this already, but what would you want others to know about, what your organization or your industry, your kind of workforce? I'll start with Ami.
Thanks, Emily. What we are asking, and the whole early learning and childcare community is advocating for this, we're asking Congress for $50 billion in the immediate term in a stimulus package to help the childcare industry from collapsing. We, hear about bailouts of cruise line industries and hotels and banks, and as others have mentioned on this discussion, nobody's talking about bailing out the childcare industry because that enables. So we continue to advocate for that, and then longer term, we are giving a lot of thought to the rebuilding and restructuring of the childcare industry in a way that better works for all families. And that also meets goals of racial justice, which we are all, if we weren't already aware, are more aware of due to recent events.
Thank you. I think we should all definitely lobby for the $50 billion for this industry. And then Courtney.
I think from a healthcare point of view, we're maybe not thinking yet in terms of post-pandemic, and I think I think it's perhaps a different context for us. What we have done in terms of sort of this next phase, sort of internally, is we've started to make, well, not started, we have in an ongoing way made some consultation services available internally. We're looking kind of in an ongoing way about continuing to make testing available, but I think partly we are also focused on the idea that we will continue to need to make these resources available to the community for the foreseeable future. And so I don't know that we've really thought to post-pandemic yet in our arena. From a behavioral health point of view, we're looking at what do we need to do to address the needs of our workforce, and that includes consultation and support services for our staff. Internally, we meet in small groups to talk with staff as we continue to adjust, the workflow and shift resources where we think that we're going to need them as well. And I think we continue to look at what types of safety concerns and adjustments we think we're going to need. But for our industry, I think the face of healthcare is going to continue to look really different as we respond to the public health needs of the community. And that's specifically for neighborhood health going to continue to mean that we ask questions about how do we continue to ramp up testing? How do we continue to address the social determinants of health that the community needs? Meaning, how do we get food to patients who have difficulty accessing food? How do we continue to provide masks to patients? How do we help support patients when they need to isolate until there's a way to address, the pandemic broadly, nationally, globally? Federally qualified health centers, community health centers, health departments are going to be called on to address this as a public health issue. And so I think for our organization, that's going to continue to mean that we address this in that way.
Yes, thank you. We appreciate your attention to all of those factors. So Kay, how about I know you did already say that you will be the last to open, but your thoughts on this question?
I think Kay is having, hi, this is Jean. I think Kay is having some connectivity issues.
Okay, let's hope she gets back soon.
So I would say advocating with Congress to provide or continue the funding and actually increase funding for essential core services for domestic and sexual violence programs, as well as funding for survivors through like the CARES Act and other funding sources. A lot of our clients, like I mentioned earlier, are lower socioeconomic. So they have lost their jobs, lost employment, so they don't have a way of providing, per se, at this point. So it's really advocating with Congress to ensure that our survivors are at the forefront and they're getting the resources and the funding that they do need. And in regards to staff, I think I would echo what Courtney was saying, really ensuring that staff are being taken care of, that they have the space to kind of talk about what's going on, they're getting the resources that they need. If we need to shift our services one area or another, we're able to do that. But it's really ensuring that, staff are not burning out, they're getting the appropriate services that they need. I know in our organization, we're really focusing on trauma-informed supervision. And so we're talking to the staff about, really about them. It's not so much administrative supervision. There is a component of that, but we really want to know how the staff member is doing. How is this affecting them? What do they need from our organization? What resources are out there to take care of them? Do they need to be referred to the Eap Program, things along those lines. So really ensuring that we're not burning out staff, but we're taking care of them as well. So you have to take care of yourself before you can take care of somebody else, right? So we need to ensure that they're being taken care of as well. But I would just say our biggest thing is advocating with Congress for the funding for our survivors, as well as the domestic and sexual violence programs who provide these services to clients.
All very important. I think Kay has gotten back, yes? All right, so we'll go to Kay.
Yes, sorry, technical difficulties there. I am back. As far as how we're trying to just deal with the ongoing crisis and the post-crisis, it's kind of just one thing after another. We've had a consulting neuropsychologist that used to come in and do groups every other week, support groups for some of our residents. And so when this started, we asked him, could you please come every week to do individual check-ins? Even though we couldn't have groups, we could do individual things. So it soon became apparent that not only did it wasn't necessary for him to kind of do check-ins with the residents, we said, would you mind doing some check-ins with staff as well? Because they were suffering kind of the same things that the residents were. And so he has increased his time to weekly, and he does check in with staff as well. That's something that we probably will continue going forward, even after things loosen up a little bit. It has been a relief. Lots of staff have said, oh, I don't need to talk to anybody. But when he opens it up and gets them going, they have actually, really been able to disclose a lot about how they're feeling. So that has been exceptionally helpful and something we'll continue. We did do our Eap program. We opened that up to people, all our employees, even if they weren't insured with us. So those are the things. And then other things that we've tried to do just to kind of keep morale up is we've implemented a couple different sequences of spirit days. And some of it's kind of corny, like one day we had a hat day, one day wear polka dots. Just trying to build, to get our minds off of the real seriousness of the nature, because we know what we're dealing with. But so we've just implemented some of those things. And then at the end, if they collected 5 out of 7 events, we had some type of prize. So we're going to continue to kind of do that too, just to try and keep spirits and morale on a high level, because we know how stressful it has been. So those are some of the things that we're doing.
Those are great ideas for all of us. So, I think we had one more thing to add, if you want to go ahead.
Yeah, thanks, Emily. I just wanted to add that the ask we're making of Congress, if you are so moved to take action as well, if you go to childcareaware.org and you click on the coronavirus menu item at the top, you'll get directed to our take action, and we would love to have you spread the word on that. So thank you.
Thank you. So I'm going to go back to some questions that we've received. And one thing was about the Virginia Department of Health return to work guidelines are published in English and Spanish. And the English version has been updated consistently, with the last edition being on June 3rd. But the Spanish was only updated once on May 8th. And according to the Spanish guidelines, COVID positive essential workers will have to get retested, but English speakers do not. And this doesn't seem fair to Spanish speaking essential workers. Have you all heard of this or have any thoughts about this?
This is Ami. I have not heard about that, but would be very interested in learning more. On its face, it seems discriminatory to me. So,
yes, and you're the lawyer in the group.
Well, not practicing, but.
Emily, the Virginia Department of Health?
Yes.
I have not heard of it either, and I wonder if out of everybody on the panel, we may be the closest to the health department aspect of things, although we are not a part of the health department, to be clear. But I would certainly be happy to forward that feedback along to see if we could get some clarification. It is also possible that it's just a matter of the translation having not kept up with the amount of information that's being pushed out. But I would be more than happy to pass the feedback along so that someone could be made aware that there is a gap between the information that's being pushed out to the English-speaking community and the Spanish-speaking community, to see if we could get some clarification for our.
That would be great. Thank you, Courtney.
Yeah.
Jean, did you want to add anything?
I was just going to add the next question, but you can do that as well.
Oh, no, go ahead.
So there was another question from a participant about just curiosity about has your organization received any support, either financial or otherwise, from federal, state, or local sources? And that's open to everyone.
I can answer from our perspective, from what's happened with us. We have actually been able to get quite a bit of support from the community and from some of our federal and state. We've gotten some FEMA equipment, PPE equipment, through our division of licensing. And so we were able to get some masks, some gowns, and things like that. And that's happened actually twice. And then our direct source, Arlington County, has also been very good about providing us with face shields, gowns, alcohol swabs, a lot of our PPE equipment. So we have certainly had to order extensive amounts, and Volunteers of America has been giving us some things as well. But we have found that we have gotten those supportive things. There were a lot of surveys that went out initially, what do you need, and answered it. And as a result, we were able to get quite a few different types of PPE. And another offshoot of that is that our community has actually supported us by bringing in meals once a week. They did some fundraising to help healthcare workers, and so that's been a big boom too. So just even the community support in that respect. So that's what has happened with us.
From Childcare Ware's perspective, we have found that childcare providers have been in a really tough spot trying to take advantage of the Paycheck Protection Program funds that the federal government put out earlier on in the pandemic. They are sometimes unbanked or don't have the same negotiating power with their local banks that larger businesses do, and so that's been a struggle for sure. And that continues to be part of our advocacy. We also have, as a national organization, received some private sector support to stand up the Emergency Child Care and Technical Assistance Center that I mentioned early on.
And I think for neighborhood health is sort of all of the above. We've been very, very fortunate. We have a really phenomenal grants and development team who's been very creative about our fundraising and has been actively pursuing community partnerships. So we've received a lot of interest from the community in ways that folks can be helpful. We've received a lot of donations, some big and some small. I suppose big is relative. And then we have received some support from different foundations as well, and that's taken all different sizes and shapes, whether it's masks or PPE. We collaborate very closely with all of the jurisdictions that we serve. We've had some physicians from local organizations that have done things like donate diapers. So it looks a little different, but I think we've had to be very mindful of staying on top of that because the need has not diminished. And so we've got folks that are constantly inventorying and reaching out to see what's available. We've had veterinary practices that have donated items to us, gloves and so on and so forth. So, but we've been very fortunate to have support from the community.
So I think Debbie is trying to log back in. But in the meantime, I wonder if we might want to talk a little bit about, you often hear when people talk about post-pandemic or whatever that might mean, is that we won't come back the same way. And I'm wondering if you all have any thoughts about like what the future might hold in terms of how you will come back. And that's sort of a random question, but.
And we have one additional question from the audience as well. Shall I read that now?
Please do.
Okay. So the plight of essential workers, especially women and people of color, is actually an extension of systemic racism we have in this country. The people who risk the most make the least amount of money and are valued the least by some employers and society in general. This is a systemic problem. So what kind of structural measures can be put in place to support essential workers, women, people of color? It is obvious that nonprofits and advocates cannot do this work alone. Who else needs to get involved and in what ways? Are there any examples where law and policies are being revamped to support this vulnerable and important group of individuals? It's a big question.
I can start. Absolutely, we need everyone pushing for this. I think one of the ways that folks who are not in the childcare industry can help is to learn about the childcare industry and what it needs. And we have lots of information on our website at childcareaware.org. But childcare has very often sort of been seen as something that is only the concern of women, and the historical roots of our current childcare system go all the way back to times of slavery, when Black women were forced to take care of the children of the white families. And so I think educating yourself about that and then raising awareness to others about how childcare and a good childcare system with well-compensated and valued providers benefits us all. We can go to work, go to school, and childcare is not just putting kids in a room with a couple of blocks. It is its own form of education. So spreading the word on that is helpful to us, as well as joining our advocacy efforts at the Take Action that I mentioned.
And the other thought that I have about this, or that I think we have about this, because this is also very true in healthcare. Some of the work, the least well-paid aspects of healthcare are done by employees from Black communities, from communities of color. And I think that before we can go to the table to advocate for policy changes, we need to make sure that we're asking our leadership to do that work also. And I think that that's one piece, and particularly in the context of a pandemic. If you're going to ask your frontline staff to sit in front of a patient who is potentially COVID positive, then you need to be willing to do that work also. And so I think as we think through some of these workflows, and one of the things that needs to be well thought through, and one of the things that that we have thought through in terms of these workflows is our leadership prepared to do the same work that we're asking of our frontline employees? And how do we broaden the conversation to make sure that healthcare includes more than just our nurses and our doctors, but that it includes everyone who is being asked to make some sort of sacrifice, so that when we go to advocate for policy change, we're speaking from a place of having walked in that work more thoughtfully. And I think that that's really important. And I don't think that that's always been the case. So that's another aspect of the conversation that I think sometimes has been missing, is that we have a gap between our leadership and the staff who's doing the work.
Such a great point, Courtney. I think we have Debbie on the phone if she wants to comment.
Apparently my technology is not working at this point. And I'm sorry, I missed the first part of the question.
Let me refresh. So the question is generally about what kind of structural measures can be put in place to support your essential workers. Nonprofits and advocates can't do this work alone. Who else needs to be involved? And what laws and policies might need to be revamped to support the workforce that's doing this essential work?
That's a great question. I think the community definitely needs to be involved. We can't do any of this work without the community and the support of the community. So I know that a lot of community members, especially in Alexandria, where I work, have really come together to assist our clients with basic need items. And so helping us provide the essential things that clients need at this point. And the support, just the support from everybody in the community, support among staff members, advocating for the funding to go through with Congress, things along those lines, really help staff and clients.
So we just have about 1 minute left. Did anyone want to say anything in like 20 seconds or less?
And we might also be able to flip through to the final slides to show some resources. There we go. Thank you.
This is the Coronavirus Resource Hub that Ami was talking about, right? Where you can find a take action. And then I think there's a couple more slides. Oh, and there are Technical Assistance Center, Emergency Childcare, and her contact information. So I would just like to thank you all for joining us today, for having this really interesting conversation, because I think that the intersection between all of the work that you are doing, both for your clients, but also with your staff members is critically important. And when we think about sort of the structural and systemic inequities that I started off talking about, I think all of what you are doing contribute to fighting against that, right? Because the people who are working to help others are often the ones who are the most vulnerable. I want to thank you all for the work that you're doing. I hope we can stay connected and move forward an agenda in the future that can support all people to live healthier and better lives. And we have some forthcoming topics for the COVID-19 webinar series. Michelle, did you want to talk about those?
Sure. Here's just a sneak preview of some of the topics coming up this summer. We'll be talking more about underserved populations and reaching them through telehealth, which we talked about extensively today, reducing intimate partner violence during the pandemic and applying lessons learned from previous humanitarian disasters, the effect of the pandemic on food systems, and then as we get further into reopening, looking at data and observations with epidemiologists and scientists. So thank you very much for joining us today. We did have some technical difficulties, so I appreciate everybody rolling through those and sticking with us. The recording will be available, as will be the slides, in short order. So thank you, everybody.